Sí. 1, 2, 3. Probamos. Sí. Sí. 1, 2. Sí. 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 1, 2. Sí. 1, 2, 3. Probando. Sí.
Good evening. I'm not sure if any of you can see me. If Lautaro is there, it would be great to speak to him for a few minutes. Yeah, you can? Great. Lautaro, where's your hair? I can't hear you. You look great. You look so much more professional.
I actually look like a person now.
You do. I'm a little disappointed. Lautaro, I'm using the Wi-Fi of the lounge where I'm at. Does it sound perfectly normal to you or suboptimal? You're sure? Okay, because I'm hearing you very low, by the way. If ever I'm hearing you low.
Is this better?
Yes, I'm not sure if it's the mic. Say that, do that again.
Is this better?
Yeah, that's much better. Yeah, it's much better. And so it's very easy for me to switch to my phone, which probably has a stronger connection. So if at any time you feel like, it's choppy in any way, because we're going to be showing videos and images, like I want this to be as good quality as possible, just let me know, and it's very easy for me to switch to my phone. Am I cutting out at all right now, or it's still perfectly smooth?
It's perfect. The connection is perfect right now.
Amazing. Okay.
So would you like me to? Okay. So we're gonna pass the microphone to the president of the Panamanian Society of Ophthalmology, and after that, I'm gonna do the presentation. Okay.
Fantastic.
Okay. Hello, Dr. Hady.
Hello, hello. Nice to see you.
El día de hoy vamos a dar inicio al coloquio de glaucoma. Gracias por la presencia de todos y la puntualidad de los que están acá. Tenemos el agrado de tener al doctor Hady para este coloquio. Damos las gracias también a los laboratorios que se han hecho presentes el día de hoy, al laboratorio Zaval, laboratorio Sanfer, Poen y Sofía. Y vamos a dar continuación con el doctor Lautaro para que presente al doctor Hady. Y alerguen.
Okay, I'm going to do the presentation in Spanish to present you to all the crowd here. El doctor Hady Saheb es egresado de medicina de la Universidad de McGill, egresado de la residencia de oftalmología también de la Universidad de McGill. Hizo un fellowship inicialmente en Bascom Palmer, primero en glaucoma, hizo un segundo fellowship en glaucoma y cirugía avanzada, segmento anterior, con el doctor Ike Ahmed de la Universidad de Toronto. Además de eso, es másters en salud pública del Hospital Johns Hopkins y actualmente dirige el fellowship de glaucoma de la Universidad de McGill, del cual muy orgullosamente formé parte, y es parte del board de la Sociedad de Glaucoma de Canadá y de la Sociedad Oftalmológica de Canadá también. Un placer presentar para mí el doctor Hady Saheb. All yours.
Thank you, Lautaro, and so nice to see all of you. And I like being introduced in Spanish. I sound so much more special than the boring introductions in English. So thank you for doing that. The worst part about this evening is that I get to see Panama, but I cannot be in Panama. And so I'm disappointed I can't be with you in person, but I'm really honored by this invitation and really looking forward to talking to you all about one of my favorite topics, which is GAP. So I'm just going to spend the next moment just setting up my screen here. If you can just give me a moment. And I want you to know that my worst nightmare is speaking alone for 45 minutes. So I don't know what the setup is with your microphones, but I would love for you to be able to have the microphone, maybe one microphone on each table, for you to be able to join in the conversation, because my goal is to get this to be as interactive as possible with comments, questions, jokes, complaints, whatever it is. If I were there in person, I would be, coming to see each of you and asking you to speak. So I don't know if it's possible to have a microphone, or maybe somebody can yell comments and then there'd be a moderator like Lautaro who could tell me what people are saying. But I don't want you to wait until the end of this presentation to make comments or ask questions. It's so much more interesting for me and for all of you to ask throughout. Y mi español es muy malo, pero entiendo poquito español, entonces si quieren preguntar en español, yo voy a try to understand. So before I start, I like to always have a few highlight pictures on my title slide to kind of get you to be a little bit curious. So GAT stands for gonioscopy assisted transluminal trabeculotomy, and the title of the talk today is the good, the bad, and the ugly. I was one of the earlier surgeons of GAT as GAT became more popular in North America. And so I learned the hard way and alone how to do GAT. I was well into my practice, so not in fellowship anymore. And I learned the hard way. I had surprises and challenges like many of the early GAT surgeons, and we kind of all learned together. And so the goal of tonight is to share with you some of those learnings with the purpose of making your GAT journey easier and better and safer for your patients. And for those of you not doing glaucoma surgery, for you to hear about this really fantastic surgery for the right patients, and to pique your curiosity as you send your patients to excellent glaucoma specialists like Lautaro. So as we start, I'd like to ask anybody in the crowd what they think this image here refers to. So the bottom left, any guesses what this image refers to?
¿Alguien quiere participar? ¿Alguno de los residentes? Te voy a poner el spotlight, Ana.
Sorry? Yeah, Lautaro, you know the crowd, so you can either put somebody on the spot or encourage them. I find in the beginning, we have to put people on the spot and then the ice is broken and people speak a little bit more. So here, the bottom left square.
Hi, good evening. My name is Anna. I'm
Hi, Anna.
a resident. I'm really interested in glaucoma, so Lautaro put me in the spot right now. But
Super.
I think what I'm seeing is an anterior segment OCT.
Amazing, yeah. And how do you think it could relate to GAT? Any guesses as you look at this image? How does it relate to GAT?
Because you're seeing the trabecular meshwork, the scleral spore, where we're going to, like the anatomic landmarks that we're going to.
Correct. So it's an open angle, but what makes this different is that you see this little line right here. It's what we call the trabecular shelf. So as you slice the trabecular meshwork with GAT, that shelf sort of falls down in the angles. This is a beautiful image, and this will come back later in the presentation. So Anna, you get to pass the microphone to your favorite neighbor who's going to tell me what they think they see right here in the middle image on top. So is this normally what your patients look like in the OR? Or does this look different than your typical patient in the OR?
Oh, hello, my name is Luis. I'm also a resident. I see
Great.
in polar, I think, polar position. I can't see the head very well, but I think it's on the left of the screen.
Correct. So it's elevated. And why do you think I'm putting this on the title slide of a GAT presentation? Any guesses?
Well, sure. I think we need to lower the venous return in order to have the least amount of hyphema and complications.
Amazing, amazing. Okay, I think my presentation's over. 2 correct answers by the residents. Absolutely. Reverse Trendelenburg with the goal of lowering episcleral venous pressure, with the goal of minimizing your intraoperative hyphema, and absolutely made a big difference in my practice as I did more and more GAT. And then you, Luis, can give the microphone to your favorite neighbor and tell me why I have this image here on the title slide of my GAT talk.
Okay. Hey, good evening, Dr. Saheb.
Hello.
My name is Edgar. I'm a first-year resident.
First day, must say.
Yeah.
Well, you get the correct picture. This is an easy one to answer. Just say something nice and you'll win.
I guess it's first time you like you're training to do the procedure.
The reason for this image is this is two of the most passionate GAT surgeons in all of the Americas, Lautaro and myself. We both love GAT, and I think we're both pretty good at doing it. At least Lautaro is excellent at doing it. And so, yeah, I think having Lautaro on this slide is very, very appropriate. So thanks for those comments. And I hope this kind of breaks the ice for all of you to make comments. I don't want you to raise your hand, just get the microphone from Lautaro and please make comments. I can't emphasize enough how much more enjoyable it is for me if each of you are making comments and asking questions. So please go ahead and do that. These are my financial disclosures, none of which are relevant. And in fact, I find financial disclosures are almost anti-GAT because GAT doesn't cost anything. You're not buying anything from any company. And so when you do GAT, you're doing less of the other mixed procedures. And so certainly no financial disclosures that are relevant for GAT. And you all know Lautaro introduced me today, and Lautaro finished fellowship almost a year ago, which is incredible to think about that. And these are some of my favorite images from our time with Lautaro. This is one of our last clinics. Lautaro and he bought the same scrubs as me, so we looked like twins. And always a pleasure to work with Lautaro in clinic. This is him with one of our senior residents who went into glaucoma and will graduate in a month from now and work in the US. And this is at our journal club in my backyard with his other mentors, Sean Cohen and Mark Midlarski. And the pandemic forced us to have a journal club outdoors just to make sure we were not indoors because we were not yet allowed. So I think you all know this, but Lautaro is a phenomenal surgeon, a great communicator with patients, with good bedside manner, such a fun colleague to have. And so we miss him a ton, and you're all so lucky to have him back in Panama, and the Panama glaucoma patients are lucky to have him. So thank you for training him so well and sending him to us in good shape and sharing him with us for a year. And I'm glad he's back and thriving. So the outline today, my hope is to do an overview of the glaucoma surgical landscape, talk a little bit about the history of GAT, an overview of the GAT technique, and then I'll dive a little bit deeper into what the title said, the good, the bad, and the ugly. Again, the goal is to give you a full, realistic picture of what GAT is about, with the hopes of optimizing your results and your patient choices. So this is a nice image of the angle that you've probably all seen over the years. This is another way to look at the angle. So we know the outflow system is either the trabecular outflow system or the uveoscleral outflow system. This thicker arrow is going through the trabecular outflow system, where the aqueous comes from the ciliary processes through the pupil and into the angle, through the trabecular meshwork, Schlemm's canal, through the aqueous veins, and then in the episclerovenous plexus. So most of our mixed procedures are in Schlemm's canal, so focusing on optimizing the trabecular outflow system rather than the uveoscleral outflow system. I love these images. They're scanning electron microscopy images of the trabecular meshwork and the Schlemm's canal. You can see here that the trabecular meshwork is like a Swiss cheese or spongy appearance. And this here is a cross-section of the trabecular meshwork, reminding us that the trabecular meshwork is multi-layered. This is the anterior chamber, so the most inner layer is the uveal meshwork, the middle layer is the corneoscleral meshwork, and the most outer layer is the juxtacanaliculaire meshwork. Finally, Schlemm's canal is here. And many of the residents will learn that the site of highest resistance is the juxtacanaliculaire meshwork. And what a great image to show you how that juxtacanaliculaire meshwork is the most dense, which explains why it's the site of highest resistance. I love this image as well. It's looking at Schlemm's canal en face, so meaning looking face on to the anterior segment. This is the pupil and this is the limbus, so where the Schlemm's canal is 360 degrees. And it just reminds us that Schlemm's canal is 360 degrees and there's multiple collector channels and aqueous veins coming out of the Schlemm's canal. And so this explains why GAT 360 can have a significantly higher efficacy than some of the other angle surgeries. So whether it's an iStent or Hydrus or hook dual blade, it's really a focal bypass of the trabecular meshwork, whereas GAT is really going all the way around 360. So you can imagine how many more collector channels and aqueous veins you're accessing by doing this procedure. Before we move on, I just want to do a IT check that the connection is still okay and that you're hearing me okay, because as I said to Lautaro, I can switch networks if you're not hearing me okay. Lautaro, can you just give me, it's still okay?
It's perfect. It's perfect.
Great. So I won't ask anymore, but please don't be shy to say, Hady, it's not, doesn't sound as good as before, because I can easily check. Super. I also like this slide because it reminds us about a basic principle of surgical decision-making. Whether it's in ophthalmology or cardiology or urology, there's a general principle that to increase efficacy, you're going to take a hit on safety. So this is a nice graph that shows us. So here in the y-axis, it's the IOP lowering or efficacy. The higher you go, the more efficacy you have. And here on the x-axis, you have the risk level. So it's the higher you go, the higher the risk is, or the lower the safety. And we know that just 10 years ago, I was in fellowship 10 years ago, and at that time, the options we had were medications and lasers, which are minimally efficacious, but very, very safe, or trabeculectomy and tube shunt surgeries, which are very efficacious, but not so safe. And so what we've done in the last 10 years, which is amazing, is kind of filled or bridged this gap with procedures that have different level of efficacy and safety with the goal of customizing your surgical choice for each of our patients. So this has really been a highlight of the last 10 years of our career. So anybody going into glaucoma now, you are living the dream because you have so many more options. It's a little bit more confusing. It's harder to learn. There's more to learn. But it's such a luxury to be able to offer more personalized options to each of your patients. A reminder of the definition of MIGS, which is now 10 years ago by myself and Ike Ahmed. So the definition is an ab interno approach, so conjunctiva sparing, minimally traumatic, at least modest efficacy, extremely high safety profile, and rapid recovery. So GAT has some of the features of GAT. Has some of the features of MIGS. So it's minimally, it's ab interno, it's conjunctiva sparing, but it also has some features that are not typical of GAT. Not typical of MIGS, because it's not necessarily minimally traumatic. You're really opening 360 degrees. And also the rapid recovery, it's not a surgery that has a rapid recovery. There is a delay in visual recovery because of the high FEMA, which we'll talk about. So I kind of label GAT as MIGS plus, like some of the other MIGS procedures. So a little overview about MIGS. And so we can separate into 3 anatomic categories: Schlemm's canal, suprachoroidal, and subconjunctival. Most of the MIGS procedures are really within Schlemm's canal. So there's trabecular bypass implants, and that can be without or with the Schlemm's canal scaffold, so the iStent and the Hydra stents. The ab interno trabeculectomy. So this is different than what we hear about in textbooks trabeculectomy, not the traditional trabeculectomy, but the ab interno trabeculectomy. And that can be done with electrocautery through trabectome or mechanically through KDB or goniotome. And then trabeculotomy. So ectomy is removing trabecular meshwork and otomy is slicing trabecular meshwork. And that can be done with GAT, ABIC, or TRAP 360. So that's what we're talking mostly about today. Suprachoroidal doesn't have anything commercially available currently, but we know that the CyPass was a useful stent here that was withdrawn from the market for corneal concerns a number of years ago. And I know that our colleagues in Panama are aware of the iStar that's being investigated in Panama, and also the iStent Supra, which are 2 of the suprachoroidal stents that we will likely have access to in the coming years. And then the subconjunctival stents, Zen and PreserFlow. And these, again, are not typical MIGS. We label them more as MIGS plus because they're not truly conjunctiva sparing and there is a bleb that's formed. So those are also MIGS plus. Any questions so far before we talk a little bit more about GAT? I want to give the opportunity to everybody to make any comments or questions.
I think so far we're good.
Okay.
People with the other glaucoma specialists, they seem to be very interested.
Sounds great. So GAT, gonioscopy assisted transluminal trabeculotomy. So this has been around, not this, but trabeculotomy has been around for decades. And I'm sure anybody in the room who takes care of kids is well aware of trabeculotomy being around for decades. But mostly it was, or historically, it was an ab externo approach. And in fact, when I was in fellowship at Bascom Palmer 10 years ago, this was our go-to approach for all congenital glaucoma. We would open the conjunctiva, dissect through to Schlemm's canal, and then slide a eye tract catheter or a Prolene suture within Schlemm's canal, turn it around 360 degrees, and then tear it to do an ab externo 360 trabeculotomy. And so this was a go-to procedure for congenital glaucoma. Most of us felt like in adults, it wouldn't work because the idea was that in adults, that trabecular meshwork would just close back again and lead to surgical failure within a year or two. And so most of us were not doing this. And I personally had a doubt that it would work in older patients because of that concept. So Devinder Grover and Ron Feldman in Dallas, Texas, were really the ones who repopularized this technique. And they were able to repopularize it by almost doing like a renovation to the ab externo trabeculotomy by now doing it ab interno. And this was in 2014 when we were talking about and investigating MIGS and learning about the benefits of ab interno surgery. And so it was really kind of at the right time to introduce a new ab interno technique. And so this really gained a lot of interest from colleagues throughout North America and worldwide, including myself. So here is a video of that surgery, but for sake of time, I'll go ahead and show you a more extensive surgery later on in the presentation. And there have been a number of studies. I'll talk a little bit more about studies on ab interno MIGS. So there's really ample evidence. So a few words about the technique. We'll go through these pictures and then go through a video later that I think will be even more exciting. So you can see here, all of this is done under gonio view. We slice the trabecular meshwork with a blade. We roll the trabecular meshwork posteriorly to expose Schlemm's canal. You might see this white area right here. Then we take this suture, this Prolene suture that has a blunted tip with cautery. We slide it into trabecular meshwork, into Schlemm's canal, behind trabecular meshwork. And you see here that this suture is behind trabecular meshwork. And then once it's in Schlemm's canal, you're pushing and pushing and pushing to allow it to go all the way around. And you see eventually that it comes back here. And once it's back there, you grab it, and then you pull on both ends of the suture with the goal of slicing trabecular meshwork 360 degrees. And that allows you to have a 360 degree trabeculotomy. So those are the basic principles of the procedure. It sounds easy and the pictures make it look great. Taro can tell you that not all the cases look this clean or this smooth or go this fast. I've just described it to you in 2 minutes. These are wonderful images. This is a UBM. And I'm wondering if any of the residents in the crowd can tell me why I know this is a UBM and not an anterior segment OCT. Maybe a senior resident, just to be fair, but any resident who wants to take a guess. And remember, there's no right or wrong answers. We're here to learn together, so don't be shy if you're not sure.
Because in the UVM, you can see the ciliary body.
Amazing, exactly. So, and why is that? The UBM is ultrasound. So ultrasound goes through opaque structures like iris and sclera. So you're able to visualize the ciliary process. So whenever you see the ciliary processes to this extent, you know that you're looking at a UBM. And what's beautiful about this UBM and how is it relevant to GAT? You see this trabecular shelf, right? So this is a trabecular meshwork which was sliced off of Schlemm's canal and just kind of hanging and floating in the anterior chamber. So it's a beautiful image. And this is similar image looking at the same structures, but using an anterior segment OCT. And you know that it's an anterior segment OCT because you cannot see the ciliary processes properly. This is using optical rays, and so light rays cannot go through opaque structures like the iris pigment epithelium or the sclera, so you do not have a good view of your ciliary processes. But once again, you have a beautiful trabecular shelf here, and this is the image you saw on the title slide. And this here is your gonio view. You see this similarly on some patients. You're able to see a trabecular shelf, and you look right through into Schlemm's canal. And what's on the outer wall of Schlemm's canal is a nice pearly sclera. And so it's a nice white area. So it's kind of nice to see that post-operatively, although we were not really able to correlate the gonio appearance with surgical success. So I look at it out of interest. I ask our fellows to look at it just for their learning, but I haven't really found that it correlates necessarily with surgical success. So here is a video that I'm going to share with you. And again, if the view is choppy, please let me know. So this is a toric patient, as you can see. We use Vision Blue. We don't use Vision Blue on everybody, but I think for early surgeons, if you're doing one of your first cases, it's nice to use Vision Blue. The Vision Blue will stain your trabecular meshwork a little bit more, so it gives you a nice improved visualization of the trabecular meshwork, which is really important. So we go ahead and rinse this case. Yeah, there's a question. Go ahead. I thought I heard a question. No?
No, I think it was one of the servers. Sorry.
Ah, okay. That sounds great. I'm disappointed. I got excited about a question. Okay. And so you can see here that this, I don't know how clear it is on your screen. This is pseudo exfoliation. So that's one of my classic indications for GAT. We'll talk about that soon. And I'm just going to move along here until we go into gonio view. So before we do that, we're blunting the suture. You're going to see that in a moment. So the proline suture, we like to blunt the tip of the proline suture, and we do that with cautery. And so why do we blunt the tip? Because if you just cut a suture, that tip is going to be very sharp. And when it's sharp, you're going to get stuck in the collector channels. But then the opposite is if you blunt it too much and you have a very big mushroom tip, then that tip is going to be so big, you're going to have resistance pushing it through. So I think Lautaro might be able to share with you that there's a just right size of the blunted tip of the proline. So for me, it's really minimal blunting of it. As soon as I see the slightest bit of rounding of the suture tip, I stop. And I'm very comfortable cutting the tip and trying again if I'm not happy with the size of the blunting of the suture. So once that suture is put into the nasal angle, I go ahead and prepare for the gonio view. And here I want to just show you for a moment, this is trabecular meshwork, and this is ciliary body. And we're using the MVR to slice the trabecular meshwork. So I'll just show you what this looks like. We're doing a horizontal slice for about 1 or 2 clock hours. And then once we slice it, I use the blade to posteriorly push and look at that nice view of the scleral spur. I love this. So I'm a geek of the angle. I love angle surgery. So I get very excited about all these anatomic findings. And so once you have that view, then you take your micro tying forceps and take your suture and insert it into Schlemm's canal. So here I'm going to grab the suture at different areas. There is an ideal place to grab the suture. If you go too far, then you're not going to have good control of the suture, and that suture is going to kink. And if you go too close, you're not going to have enough suture in front of you to end up sliding into Schlemm's canal. So that's the perfect distance. And then I'm going to show whoever's operating with me how to grab it too far. So that's too far to grab it. You're not going to have control there. And then I go back to grabbing it at the perfect distance. So here we're grabbing it at the perfect distance. We slide it into Schlemm's canal, and then you need to make sure it's in Schlemm's canal. This is another part of surgery where learners will make mistakes, because if your suture is not in Schlemm's canal, what it can do is go from scleral spur to the ciliary body and then go through the ciliary body into the suprachoroidal space. We call that a posterior dive. And so it's really important for me that first clock hour of the suture going into Schlemm's canal, I find it critical to be paying attention to make sure that it's clearly behind the trabecular meshwork. So we'll go ahead and watch me push that in. So as you can see, I'm just sliding in the suture. The first few slides tend to be very easy. And then once you reach 180, you tend to meet a little bit of resistance. So I'm just going to move you along here in the surgery. So here we go. We continue to push. And at some point, you're going to see the suture come back on the other end. So you're seeing it right here. I don't know if you can see it on your screen, but this is one of those moments where like everybody's eyebrows go up and people start smiling and the fellows saying, yeah, and the staff saying, yeah. And there's just this moment of excitement when the suture comes back. And so you'll see now that the suture is going to become visible in that initial goniotomy that we created. So you're looking right over here, you're going to see the sutures there. And so what we do is we grab that suture with the micro-tying forceps, we pull it centrally, and then the assistant will grab the other part, the other suture right here, and you pull on both ends with the goal of doing a 360 trabeculotomy. So I'm going to take a moment in a second to see if there are any questions or comments from the crowd. This is the basics of the GAT technique. So we're just going to go ahead and pull that there, and then we'll take a moment for questions. So you see here how we just pull on that right there, and that's a 360 trabeculotomy. Okay, great. Any comments or questions before we move on to a little bit more detail about GAT efficacy and safety and some of the literature?
I think everything has been very, very clear. I want to ask if you have any particular pearls other than the, for example, the using the blue staining of the trabecular meshwork for people that's starting on GAT.
Absolutely. I've got a whole slide on your ideal first cases. And so absolutely, I will cover that. And if, I mean, Lautaro, you are well positioned to know what's good for your first cases, as you did your first case more recently than I did when you were in fellowship with us. So also whatever I add there, please feel free to make your comments. And in case the rest of the crowd doesn't know, you've got great thoughts and comments about GAT. You made me, learning with you made me a better surgeon. And so really, I'm serious in saying that. If you have any comments or additional pearls for the audience, I hope it's clear that you're more than welcome to share them.
Which are
yes.
the primary indication of this surgery? The primary indication.
Absolutely. I will. So I'll go more into depth of that in a few slides, but just to answer your question, since you've asked it, my main indications are uncontrolled secondary open angle glaucomas. So what do I mean by secondary open angle glaucomas? Is pseudo-exfoliative glaucoma, pigmentary dispersion glaucoma, and juvenile glaucoma. So those are my classic indications. There's some uncontrolled mild to moderate primary open angle glaucoma that I'll also do GAT on, but only the mild to moderates. But for the secondaries, I'll do it on anybody who's uncontrolled, just because this surgery works particularly well in secondary open angle glaucoma. Does that answer your question?
Yes, it does.
Great. So we've done an overview of the surgical landscape. We've talked about the history of GAT, an overview of the GAT technique. And so now is fulfilling the title of the talk, the good, the bad, and the ugly. So what is the good, in my opinion? For me, the real highlight of GAT is its efficacy. It's significantly more efficacious than other Schlemm-Canal MIGs. The cost effectiveness is incredible. I mean, all this costs is a Prolene suture, which costs a few dollars, and viscoelastic. You compare that to the cost of the stents that we do in MIGs, and the cost effectiveness is simply uncomparable. I don't think we should make decisions strictly on cost effectiveness. There's some patients where this is not the best surgery for them, and I do a lot of MIGS procedures, iStent, hook dual blade, Hydrus, Zen, tubes, PreserFlow, etc. I think all of these have a very important role in our glaucoma patients, but I think especially in a public healthcare system like ours in Canada, or systems where there's restricted access to resources, it's important to keep in mind. So again, this doesn't sway my decision completely, but I think it's on the back of my mind that this procedure is so cost effective. I think appropriate patient selection is so important. You know, I think earlier on in my GAT journey, I didn't have as good of a patient selection as I do now. I've learned from the literature, I've learned from my own experience, which patients it works best in, and that's what I've shared with you a minute ago, and I'll share with you again in a few slides. I really think your success is going to be dependent on choosing the correct patients for GAT, and that's been a really big learning for me. And the other point is surgical learning. I've become a better surgeon because of GAT. My fellows have become better angle surgeons because of GAT. And I've become a better teacher because I teach GAT. GAT surgery is either the most or one of the most challenging angle surgeries. It requires dexterity, it requires comfort with the angle, it requires an ability to troubleshoot and manage surprises. You have to be able to roll with the punches and go with the flow as things happen during GAT, because you're doing a 360-degree procedure where blood can be an issue, cyclodialysis cleft can be an issue, patient cooperation can be an issue. So there's a number of issues that can arise. So I truly believe that I've become a better surgeon and specifically a better angle surgeon because of GAT. And that's kind of rewarding. So these are all highlights of my GAT journey. This is a slide that's busy. We're not going to go through it all, but this is a summary that one of my superstar residents developed as we were reviewing the GAT evidence. And essentially, I think I heard something. If there's a question, go ahead.
Yes. What happened is you have a primary failed trabeculectomy. Can you perform this in those patients? And
yes.
And on the other side, if you already did this GAT to one patient, can you perform a trabeculectomy? And if that doesn't work?
Yes, great questions. I love them. So the first question is, if you've had a failed trabeculectomy, can you follow up with a GAT procedure? I want you to know that my initial answer to that question was, of course not. If you've created a trabeculectomy, you've bypassed the trabecular outflow system. So why would you go back and open a trabecular outflow system that has not been working for years since the trabeculectomy? So my initial answer was, of course not. So I never did that. But there was a really good paper by Grover's group that looked at GAT surgery after failed trabeculectomy or failed tube. So I was very surprised to see the results of that paper. And that paper showed that this has good efficacy. So I would say that if those patients fulfill the other criteria that I have, so uncontrolled secondary open angle glaucomas, I will still consider doing GAT after a failed trab or tube if they otherwise would meet the criteria. So let's say you're advanced primary open angle glaucoma, I would not do GAT on you prior to a trab. So I would definitely not do GAT on you after a trab. But if you would otherwise be a good patient for GAT, so an uncontrolled secondary open angle glaucoma, for example, I would do a GAT. So that's to answer your first question. The second question is, can you do GAT? Can you do a trabeculectomy after GAT? And absolutely. That's one of the benefits of doing GAT, is that it's conjunctiva sparing, it's ab interno, you don't touch the conjunctiva. So absolutely, if it fails, you can do a trabeculectomy or tube shunt surgery without an issue. Something I would mention to the glaucoma specialists in the group is you need to expect that you might have hyphema post-trab or post-tube if you've done previous GAT. Why? Because your trabecular meshwork is open 360 degrees and you suddenly lower the pressure from 20s to 5 or 6 or 7 if you've done a trabeculectomy. And so what happens is you have reflux of blood into the anterior chamber. And so I almost always expect a 1 to 2 millimeter hyphema on post-op day 1 after my trabs and tubes in patients with prior GAT. So I think if you expect it, you won't be surprised by it. Maybe give a little bit more steroids in your post-trab patients because of the blood. But otherwise, I haven't noticed to be a problem as long as you're not shocked by the hyphema. Does that answer your question?
Yes, it does. There's another question coming from Dr. Michael Politis that's on Zoom. He's asking about if you can do GAT on patients that have secondary glaucoma due to silicone oil.
What a great question. The answer is yes. There's a nice paper, not specifically on silicone oil patients, but more on post-vitrectomy patients. So this is from the ACTAS group in Turkey. And it shows really good efficacy post-vitrectomy. And so after silicone oil, I would be comfortable doing that. And so with silicone oil, ideally, you don't want to have too much of the silicone oil going into the subconjunctival space with a tube, for example. So usually in silicone oil patients, if there's a lot of silicone oil in the anterior chamber, we would do an inferior tube. So I might be hesitant to do it in a patient that has a lot of silicone oil in the anterior chamber, because those oil bubbles might end up going into Schlemm's canal and the episcleral plexus. But if there's just a few bubbles superiorly, I would probably still do it. And then, of course, one of the mechanisms for glaucoma and silicone oil is if there's peripheral anterior synechiae. So you would have to either do gonio yourself as a retina specialist, which I know you never do, or just expect that the glaucoma specialist would do a gonio. And if there are peripheral anterior synechiae 360, then that would be a contraindication to doing GAT. But if the angle is open and there's not too much silicone in the anterior chamber, absolutely, I would proceed with that. And in fact, I would prefer to do that than do a trabber tube. Because if you do a trabber tube, you're going to have sudden lowering of the pressure, more so than GAT. And you're going to have a higher risk of a suprachoroidal hemorrhage, because we know vitrectomized patients are at higher risk of suprachoroidal hemorrhage. So really for me, post-vitrectomy, if you're otherwise a reasonable candidate for GAT, I do like to start with GAT because I think the risk profile is lower than doing a trabber tube. Does that answer your question, Michael?
I think it does. I have a piggyback question on that one. Do you think there's a role of hemi-GAT, like 180 inferior hemi-GAT for that? Would you prefer that instead of doing 360 if there's a lot of droplets in the AC?
That's a great point. So I guess you would do a hemi-GAT inferiorly. I love that idea. You know, there's been a lot of interest in hemi-GAT. My secret opinion about that is it's because it's easier and quicker to do a hemi-GAT. So surgeons want to do quicker surgeries. I generally feel like if I'm in the eye and I'm going through the effort of doing a hemi-GAT, might as well just do a full GAT with the goal of having better efficacy. But there are a lot of surgeons doing hemi-GAT, and there's no great papers out there, in my opinion, yet, but there's a number of sort of modest quality papers and a lot of abstracts and presentations at meetings showing that hemi-GAT probably works similarly to 360 GAT. And so I'm not convinced yet to switch my technique, but I think in cases where doing a hemi-GAT is particularly advantageous, I think the initial evidence suggests that hemi-GAT is a reasonable approach. And so yes, to answer your question, Lautaro, I think it's a great idea in these patients with silicone oil bubbles superiorly, and you can just do the hemi-GAT inferiorly. So I love that idea. And Michael, I just wanted to say it was nice to see your face for a few minutes there. Michael also spent a couple of years in Montreal. And I actually met Michael when he was a medical student at Bascom Palmer, and I was a fellow. He was rotating there, a little superstar young medical student from Panama, and we got to know each other a little bit. And then when I came to Panama, I reached out to Michael to ask him for advice. And then he ended up in Montreal doing a fellowship at McGill, and we connected before that. So anyway, all this to say, I've got a few nice connections to Panama. So nice to see you, Michael. So this was the slide that I mentioned earlier. So how can I give you a high-level summary of all the studies? So one, there's ample evidence that GAT is efficacious in POAG and secondary open-angle glaucoma. There is a suggestion that GAT works better in secondary open-angle glaucomas. And why? We think because in secondary open-angle glaucomas like pseudo-X, pigmentary, juvenile, probably the disease process is more localized to the trabecular meshwork. So opening the trabecular meshwork in these patients where the disease process is more focused in the trabecular meshwork, it tends to work better. That's our hypothesis so far. We think there's, the third point, we think there's increased risk of failure in advanced POAG. So that's why I tend to not do this in advanced POAG. And there's no evidence yet about the added benefit of viscodilation. If you're at meetings listening to GAT surgeons, some of them will mention that they use the eye-track catheter and viscodilate. So what does that mean? The eye-track catheter, some of them you're able to inject viscoelastic. So you bring the eye tract catheter 360 degrees. You inject viscoelastic as you're coming back with the idea of stretching Schlemm's canal and dilating the collector channels and aqueous veins. Conceptually, it sounds very exciting. I'm not convinced that it makes a difference, and there's no evidence yet that it makes a difference, but you'll hear about that from surgeons, and the video is certainly really cool and interesting. So I just wanted to share with you that that is being done by a number of surgeons, but I don't feel it's evidence-based yet. I'll move on to one of my most common indications, which is the younger patients. So this is a paper that we published in the Blue Journal 2 years now, and this is a lead author Hady Saheb, one of our star junior medical student, junior residents. And we know that trabeculotomy works well in congenital glaucoma. Remember, that was one of the first things I said as I talked about the history of GAT. It worked at ab externo. So it was my impression that GAT also worked particularly well in younger patients. There was no other publication specifically looking at this patient population. So I wanted to share our results with the rest of the glaucoma community with the goal of identifying this surgery as really an ideal surgical option for these younger patients. So we decided to look at the 1-year efficacy and safety of GAT among young to middle-aged adults. So what did that mean? That meant patients 19 to 64 years old. And we used standard surgical success measures of pressure below 21 and lowering the pressure of 20% or more, and also criteria of less than 18 and 20%. And we looked at the standard things: change of IOP, change of glaucoma medication, change in best corrected visual acuity, and the standard safety measures and adverse events. So our patients had a mean age of 46, once again, between 19 and 64, a nice mix of females and males, mostly solo GAT, but some combos. About half the patients had previous SLT, average central corneal thickness. And these are patients with uncontrolled glaucoma, a mean IOP of 28 millimeters of mercury on 4 medications, right? So this is not glaucoma light. This is the real deal uncontrolled glaucoma with a mean visual field mean deviation of -9. So once again, real uncontrolled glaucoma. Most patients were either POAG or juvenile open-angle glaucoma with a few other pigmentary and pseudoexfoliative glaucoma. So we see here a nice success rate in the 80%, in the mid-80s. And the main reasons for failure were the need for second surgery. So the question you asked, can you do a trabeculectomy or tube? We had a few patients who underwent tube after, one patient with a combined phaco-zen and one patient with non-penetrating, and then a few patients who had inadequate IOP reduction of less than 20% from baseline. So we looked at what are risk factors for failure. So which patients tended to fail more than others? And we identified on multivariate analysis one predictive factor for failure or success. And that was younger age group was predictive for surgical success. So here we separated the cohort. Remember, it started initially from 18 to 65. We separated from 18 to 39 versus 40 to 64. And if you were part of that younger age group, you were 8 times more likely to have surgical success. And that is dramatic in my opinion. And that was my clinical experience before actually looking at the data objectively. And so this was not a surprise, but nice to see that our clinical impression was confirmed by this study. You see here a 50% reduction IOP, which was statistically significant, a 50% reduction in medications, which was statistically significant. And as we look at the safety, we see no significant change in best corrected visual acuity, cup-to-disc ratio, visual field, and RNFL measurements. Complications, right? So I'm going to ask you to spend a moment thinking about this and comparing it to the other MIGs like iStent and Coke Dual Blade and Hydrus. There is no question that the complication rate is higher. So cyclodialysis cleft in this patient group, we had 1 patient. Hyphema, 70%. That's crazy. A lot, almost everybody, you can just assume that patients are going to have hyphema. IOP spike in about half the patients. What's interesting about IOP spikes, it tends to happen most commonly at post-op week 1 or post-op week 3. It can be dramatic, 30s, 40s, 50s. And initially, my impression was that if you had an IOP spike, then that's probably bad news and probably increases your risk of ultimately failing. But this study did not show that IOP spike was predictive of failure. So what I now tell patients when they have IOP spikes, I say, I'm not thrilled that you have an IOP spike, but I'm also not worried. Most patients with IOP spikes will resolve as we taper the steroids and restart medications. So I'm less worried about it now than I used to be. And I reassure patients that this is a pretty common event and in most cases tends to resolve. But all this to say, this is not the smooth rolling that we tend to have with other MIGS procedures. So the conclusion was that the GAT works well in younger patients. The younger you are, the more likely you are to succeed with GAT. And again, why is this that we think GAT works particularly well in those youngest patients? Likely because the disease process, the pathophysiology is more localized to the trabecular meshwork. So by doing this surgery that opens the trabecular meshwork, you're having really, really interesting efficacy. So that's the publication. So why don't we do one case just to illustrate kind of a classic GAT patient. And so here is a 32-year-old young female referred for uncontrolled juvenile open-angle glaucoma for years, controlled for years and recently unstable on Duotraf, Simbrinza, pilocarpine, and Diamox. So that's 5 topical agent plus systemic acetazolamide. The Diamox was not tolerated, so the patient had to recently stop it. Significant family history of glaucoma and no ocular surgery. The pressure was 30 and 45 on all these medications. So once again, this is really uncontrolled glaucoma. And on Gonio, the fellow wrote no structures visible. And so the concern of the fellow, this was not Lautaro, this is before Lautaro, the concern of the fellow is that the angle was abnormal and this patient would not be a good candidate for GAT. This was the OCT. We see that the OCT on the left is perfectly healthy, on the right eye, also healthy, but it seems that the superior peak is likely a little bit weaker than the inferior peak. And we see here that the visual fields are relatively normal on this side. Here, maybe a little bit of inferior defect. And again, in the context of the superior Arnefeld defect, this is likely real glaucoma visual field defect. So in summary, this patient had a pre-parametric juvenile open-angle glaucoma, more so in the right than the left, uncontrolled IOP, more so in the left than the right, and an atypical angle. So the fellow said, the angle is atypical, I want to do a tube. I know GAT works well in juveniles, but this patient has an atypical angle. I'm not comfortable booking the patient, which I thought was reasonable. But I like to challenge our fellows. And I said, I'm pretty convinced that this angle likely is normal. Why don't we do anterior segment OCT? So here's our anterior segment OCT. And what we see here is a beautiful corneoscleral junction. You see the white sclera and that beautiful junction with the cornea, which is more dark. And this junction right here is a scleral spur. So that suggests that the trabecular meshwork is anterior to that. And so we know this angle is open and this structure looks relatively normal to me. So I was confident enough that I could go into the OR and open Schlemm's canal. So I went ahead and booked this patient for GAT surgery in both eyes relatively urgently because the pressure was so high, and she had a phenomenal result. So you see here on post-op month 1 how excellent the pressure and the vision was, and I've seen her now for a few years post-op, and the pressure is still in the mid-teens and off medications. So this is a classic, truly juvenile open-angle glaucoma, much younger patient. The results are very often this good. So not for everybody, but in this patient group, very often is this good. And there are a number of studies other than ours that showed how well GAT works in these younger patients. I'm going to shift gears a little bit to talk about surgical decision-making, and just wanted to give another opportunity for questions or comments as I transition to the next section of this presentation. Including the residents, your group is really good and knowledgeable. So if you have any questions or comments, please feel free. Yeah.
Is there a special type of microforceps that you need, or a specific one that you recommend in order to do GAT, or any?
Yeah.
Would work?
I think the simple answer is any microforceps likely would work. What I use is the MST set. So MST has a series of really nice micro instruments for the anterior chamber. If any of you are thinking of doing anterior segment work, it's just wonderful. They've got micro tires, micro graspers, micro scissors. And so looking up MST and the various instruments they have is really, really exciting if you're doing anterior segment work. For me, myself, what I use for GAT is the micro tires. So if you've got an MST anterior segment tray, when you open it, it's the initials are TY for tires, and those are what I use. I think why do I like that is because the micro tires are kind of like this. They're two flat surfaces right here that can grab the suture, and it can grab it anywhere here. There's also the micro graspers MG, but that tends to only grab at the tip, so you would have less of a platform to grab the suture. So again, my go-to is the micro tires from MST. I think something that's available in many ORs, if you don't have the MST set, are the ILM peeling forceps from our retina colleagues. I would use that if that's the only thing you had, but I would caution against that because the micro tires I've used don't really go like this, right? They go more like this, right? They only close at the tip. And so that would limit the platform that you have to grab the suture. You would have to grab the suture perfectly every time. And what you really want is something that opens and closes like this. So you have a longer platform to grab the suture. I hope that makes sense. Yes, I see somebody else has a microphone.
Yeah. When you recommend to start using pilocarpine after the surgery, in which patients?
So great question. I would say the majority of patients, like maybe 60 to 70% of patients on post-op day one have pressures in the mid to low teens. And so those patients, I will stop their glaucoma medications. Because remember, in GAT, one of the challenges post-op is hyphema. You saw that 70% of patients in their study got hyphema. And so reducing the risk of hyphema is a big priority in the early post-op. So actually for me, I prefer the pressure to be kind of 15 plus, because then you're well over the episcleral venous pressure and you're less likely to have hyphema. So that's why I have a protocol. If the pressure is below 18, I don't start any glaucoma medications and I don't give pilocarpine either. As soon as the pressure goes above 18, I start prescribing pilocarpine, either 1% or 2%. So that is my first line agent for lowering IOP in the early postoperative period in GAT patients. Why? One, it lowers IOP even in non-GAT patients. But in GAT patients, the idea is that you're pulling, if this is the angle, you're pulling on the iris and potentially you're pulling on the trabecular shelf. So I think the mechanism of pilocarpine is particularly useful in post-GAT patients to optimize the anatomic result. And so just to go back to your question, I start pilocarpine as my first line glaucoma medication in the early postoperative period once the pressure goes above 18. Does that answer your question? Anything else for now? Are we good, Lautaro?
Yeah, they turned off the microphone. We're perfect. Thank you.
Super. So here is my glaucoma treatment algorithm. Glaucoma specialists don't like algorithms. We feel, and so do I, that everything is so personal and there's an art of decision making, and I agree with all of that. As a teacher, I am always challenged by residents and fellows asking me, how did you decide to do the surgery? And why did you decide to do surgery? And those questions have challenged me and have inspired me to find a way to be reproducible with my decisions. I hope that the decision I make today is the same as the decision I make next week and the week after. And when I review my charts on the day of an operating room day, I hope that I look at my decision and I agree with that. So if I'm able to be reproducible with my surgical decision making, I have challenged myself to create an algorithm of how I make surgical decisions. And this algorithm allows me to teach better and also to learn better, because this is not going to be the same in 5 years from now, because there will be new surgeries and new evidence. And my goal is that if every year or two that I evolve my own decision making, I'm able to evolve this surgical algorithm. So I'm sharing this with you here, and this can be an hour talk on its own. And if I come and meet you all in December, I'm happy to talk more about this. But this is, the purpose of this is to show you where GAT fits on my surgical decision making. So where does GAT fit? One, it only fits in the uncontrolled glaucomas. I personally do not do GAT on controlled glaucomas. I don't think the risk of GAT is justified if your pressure is controlled. So I do it on uncontrolled glaucomas, and I do it if your target is in the mid to high teens. So these are the primary open angle glaucomas that I was mentioning that have mild to moderate glaucoma, so not advanced primary open angle. But I do it on anybody who's got uncontrolled secondary open angle glaucoma, because I think GAT works particularly well in this patient group. So that's to kind of show you a visual of where GAT fits into my surgical decision making. So I'll spend a few minutes on learning how to do GAT, and I know I need to wrap up in the next 10 minutes or so. So I think for those of you considering doing GAT, gonioscopy is obviously a very important skill. I know many of you are already comfortable with that in clinic. And once you feel like you're a gonio expert in clinic, I think you can start doing gonio intraoperatively. I encourage our learners to do gonio after phaco, for example, just put on a gonio lens. And the first move that I tend to show our learners is using a viscoelastic cannula under gonio view. Just taking that viscoelastic cannula, putting it into the eye, injecting, moving it side to side, simulates a lot of the movements we do in angle surgery. So that's usually the first thing I ask our learners to do. And this image here is just reminding you that when we're doing angle surgery, we have to rotate the patient's head away from us and ask them to look away from us, and also rotate the scope towards the surgeon. So that's important. And then also when I'm teaching angle surgery, I think that there's, in an ideal world where you have access to everything, and I have that luxury at McGill, that you can kind of graduate the learners from one procedure to another. I think the easiest one to teach is a trabeculomeshwork stripping technique like Cahook dual blade or goniotome or trabectome. After that, I think stenting is the next step, like an iStent or Hydrus. And then I truly feel like GAT would be kind of the most challenging one to teach, the most challenging one to perform. So I kind of like to graduate our fellows from, TM stripping to Schlem canal stenting to GAT. When you're looking at the angle, it's really important to look at the angle not from above, like this red arrow, but really en face. Why is that? One, it gives you a better view of the angle, and it allows you to see the anatomy better. So I'm going to show you two images right here. This on the left is looking from above, and this is looking en face. It might not look so obviously different to you, but I want to highlight to you how much better the view of the trabecular meshwork is here. The trabecular meshwork is actually wider because you're looking at it en face, right? As opposed to from above, where the trabecular meshwork is shortened. And so it's really important to make sure the patient's head is moved away enough from you and the scope turned towards you enough to have that nice view before you're doing these procedures. I think as you get very experienced, you can you can work in suboptimal visualization, but especially for your early cases, you want to really make everything as optimal as possible. And if you have a poor view, the fellows are often saying, oh, I'm not sure why I have a poor view, what's going on? The reasons are often either blood on the cornea, because you incise the cornea close to the limbus and have a little bit of blood go between the gonial lens and your cornea, or corneal folds as you're pushing too much on the cornea with your gonial lens, or red blood cells in the anterior chamber, which the solution is to inject viscoelastic to move that away. I showed you already the image of the extreme reverse Trendelenburg to reduce the episcleral venous pressure. This really helped my level of intraoperative gonioscopy. I did this maybe a year into my GAT journey, and it really made my intraoperative experience less stressful and less messy. Other common challenges, cauterizing the Prolene suture. We talked about it being just right. So for me, it's really the minimal amount of cautery, just enough to round the tip so it's not so sharp that it gets stuck in the collector channels, but not too big that it's so big and leads to a lot of resistance as you're pushing through Schlemm's canal. The entry into Schlemm's canal is really important, again, to make sure you're in Schlemm's canal and behind the trabecular mesher. If you want to see that suture passing in front of you, because if it's not visible to you, there's a risk that it's going through the ciliary body into the supracoroidal space. And then a reminder that it's normal that after 180 degrees of suture passage, the suture, you have a lot more resistance to pushing forward. So the trick there is to do smaller pushes. You saw in the video, I was really kind of pushing big pushes, but once you get to the second 180 degrees with more resistance, you have to do smaller pushes, and you take the suture and go right along trabecular meshwork, so that the vector of movement is optimized and allows you to push it forward despite the resistance. Corneal striae drive us nuts. I have an angry emoji right there. The possible causes are too much pressure from the gonial lens. Learners do this all the time. The more stressed you are, the more worried you are, the more you tend to press with your gonial lens, and that causes corneal striae, and that can be pushing either the entire gonial lens, or if you're tilting the gonial lens. If this is your cornea and your gonial lens is pushing here or here, you're going to have focal striae. Also, if you don't have enough viscoelastic in the eye is going to be softer and the cornea is going to be more likely to have striae. And then locking the corneal wound is another common cause of corneal striae. If you're in the corneal wound and you're pushing this way, you're going to lead to corneal striae on the edge. So I always remind the fellow and the residents, use the wound as a fulcrum. If this is the wound, you don't want to be moving like this. You want to be moving like this, using the wound as a fulcrum to not hit the edges of the wound and lead to those striae. This is what Lautaro was asking, your patient selection for your first cases. Wide open angle, no brainer. It's going to give you the best view. Pigmented trabecular meshwork. So in a non-pigmented trabecular meshwork, it's going to be harder to see the trabecular meshwork. So that's not an ideal scenario for your first cases. I'm sorry about this noise, just a moment. I'm sorry about that. So pigmented trabecular meshwork is going to facilitate visualizing the trabecular meshwork, so you're in the right place. A clear cornea, you don't want your first patient to have a temporal pterygium or arcus senilis. Cooperative patient is probably one of the more important ones. You don't want a patient who's moving a lot. You want to be able to tell them to look away from you and stay there. Pseudophakic helps. Why? It's just a little bit less stress on your first cases of puncturing the lens, for example. But usually intraoperative myocall is enough to constrict. Excuse me, there's a last announcement, excuse me. I'm in an airport lounge, so I apologize about the noise. So I was saying that in pseudophakia, just a little bit less stress, but even if you're doing the phakic patient, as long as you're putting in myocall and making sure not to puncture the lens, it's okay. And why good vision and contralateral eye? You know, I want your first cases to be pleasant for you and for the patient. I feel like for learners or early surgeons, the risk of hyphema is a little bit higher. And so you don't want to end up with the rare case of like counting finger vision for a few weeks post-operatively, because that's not fun for you or for the patient. So we're moving on from the good to the bad. So the bad is that their visual recovery, as I just mentioned. I mentioned to my patients, vision can be blurry for 1 to 4 weeks. So I warned them of that. Most patients are kind of in the 20/30 to 20/50 range, but there's certainly a reasonable minority of patients that can be 2100, 2200, count fingers, hand motion. So rare-ish, but it definitely still happens. Physical restrictions post-op. I am very strict with this with my patient. I tell them in the initial consent discussion, 2 weeks of no physical activity, your head always above your heart, including pillows under your head when you're sleeping, and also no bending over. IOP spikes, we saw that happens in up to 50% of patients. Steroid response, which is part of the cause. And these complications, cyclodialysis cleft right here, which we'll talk about in a moment. And finally, the ugly. I hate to end this talk on the ugly, but there's ugly in every surgery and certainly there. So I'm sharing with you literally my worst complications. Can anybody tell me what they think they see in this image? I think this is, I have this question and then another question for the residents, and then I'm going to stop. So can anybody tell me what they think they see here?
Cyclodialysis cleft.
Aha, amazing. So this is an anterior segment OCT. You see here that the angle is normal, and you see here that there is a complete connection between the anterior chamber and the supraciliary space. So this is a cyclodialysis cleft caused by yours truly or my fellow, I can't remember. But essentially this patient developed cyclodialysis cleft, and I'll show you more about that in a moment. And how about this right here? Can any resident tell me what they see here? Or Lautaro?
A total hyphema.
Aha, and yes, you can label it even beyond that, an 8-ball hyphema when it's black and dehemoglobenized. So when you've lost the hemoglobin, the blood can become black, and it's what we call an 8-ball hyphema. I agree. So this is a nice paper that we published recently showing 2 patients that had cyclodialysis clefts after GAT surgery. And so I'll show you here the image of the first patient. And you see that this patient on post-op day 4 had a pressure of 4 and a cyclodialysis cleft of 40 degrees and a ciliocroidal effusion of 623 microns. And over time, you see this cleft and the choroidal effusion decreased over time and eventually closed. And this patient had a wonderful outcome of a vision of 20/20 with pressure of 11 off all medications. So this happens to be a good outcome. And this is another patient. You see the cyclodialysis cleft over here on the top left. And that was initially imaged on post-op day 6 with a pressure of 3. And we see that over time that the cleft got smaller and the ciliocroidal effusion got smaller as well, with ultimately a really good outcome of 20/25 with a pressure of 17 on no meds. So cyclodialysis clefts are not fun. I think if the pressure is low, you need to suspect them, because normally with GAT, the pressure should not be lower than 10. And I have found that following them with ASOCT is a non-invasive way, easier than UBM, to follow these clefts and choroidal effusions. This is my worst complication. This is my classmate's father. He came to me as a 72-year-old male with uncontrolled pseudoexfoliative glaucoma. Pressure was uncontrolled at 24 on 3 medical agents. And this, I'm going to read you the message to my friend. So my friend, who's my medical school classmate, I sent him a text message after the surgery because he was asking me how it went. I said, "Good morning, QC. Your dad's surgery was a textbook success. In fact, I will likely use it for video teaching of the technique because it went so smoothly. I'm so happy for him. The next few months will give us an idea about the ultimate success of the surgery, but technically it was really great. Have a great weekend." He's saying that such good news. Thanks so much for taking care of my parents, because I'm also doing cataract surgery on his mother. So the surgery could not have been better. Perfect, uncomplicated surgery. Then over the weekend, He says, hey, sorry to bother you. Is it normal that my dad does not see anything in his left eye by now? He described it as a gray curtain. I assume the pain is normal post-op, but the vision, I'm not sure. So I'm thinking, oh man, what's going on? So 8-ball height FEMA, absolutely. We ended up needing to do a washout at post-op week 2. I rarely do washouts. This was the worst one I've ever experienced. The hyphema, despite waiting 2 weeks for it to liquefy, was one massive clot that I could not remove with irrigation aspiration. I could not. I needed to use the vitrector. And despite using the vitrector for over an hour, I was only able to debulk the hyphema. There was still blood all over the ankle. So followed him for another week, did daily injections of TPA, finally liquefied the clot enough to go in and do a second washout at post-op week 3. TPA was very useful to liquefy this clot. Ultimately, this patient needed CPC and developed a relative afferent pupillary defect, and their vision is in the count finger range. So a terrible outcome, unfortunately. This is my only case that went this bad, but it's important to know that all surgeries have complications. So I don't want to end on this negative note. I hope we went through a nice overview of the glaucoma surgical landscape, the history of GAT, overview of the GAT technique, and a deep dive on the good, the bad, and the ugly. I do want to highlight the good before we get too sad about the last complications. So again, the efficacy of the surgery is particularly superior to other MIGs in the right patients. The cost effectiveness, it's so important to have the right patient indications. So again, my classic indications are uncontrolled secondary open-angle glaucomas. And anybody thinking about doing this, enjoy the surgical learning. You will definitely become a better angle surgeon by doing GAT. And you should all go and join Lautaro as he does GAT, because he's a great GAT surgeon. The bad, visual recovery, it's important for your patients and you to know that patients can have blurry vision for a few weeks post-op. The physical restrictions post-op are really important, and it's important to not be surprised by IOP spikes. And the ugly, there are rare but devastating complications like any surgery, but some of these are particular to GAT. So please keep them in mind. Thank you so much for your comments, for this opportunity to talk about one of my favorite topics. I've left my email here in case there are any additional questions that come up, and I really hope to meet you all, hopefully soon enough in person, either in Panama or elsewhere. Any other questions for now?
I think it was a very, very great presentation, actually. I'm very, very happy to have you at least in Zoom. Hopefully, we're going to see you in December. It would have been better to have you like personally, but time restraints and everything else don't allow that to happen. Yeah. So are you at the airport right now?
I am at the airport, and so yeah, I'm at the airport, but I'm available if there are any questions or comments. So there's no rush, but otherwise this is great.
We have another question here.
Super.
Hi, hello. Any comments about the blanching after the surgery?
Yes. Lautaro knows that's one of my favorite things to do at the end of surgery. So at the end of every surgery, after we rinse out viscoelastic, we inject BSS and raise the pressure to extreme levels. Doing this in glaucoma patients initially is kind of scary, but I've been doing this to all my GAT patients and I haven't really regretted it. So I go up to 50s, 60s, enough to make the cornea swell and the patient to have pain, unfortunately. And so I do this with the goal of testing what we call the episcleral fluid wave. And so what that is the BSS goes and fills the Schlemm's canal and then the collector channels and aqueous veins. And if you're able to do that, you truly blanch the conjunctival and episcleral vessels. And in some cases, it's really dramatic. So why do I do that? For two reasons. One, I think it's prognostic. So I think the more blanching you have, the more likely you are to have surgical success, because it suggests that the episcleral veins are more patent, so you're more likely to do well post-op. So that's prognostic, but I also think and hope that it's therapeutic. So somehow by rinsing the outflow system multiple times at high pressure, somehow I'm dilating the collector channels or aqueous veins and hopefully releasing any debris. So I do this like 4 to 6 times at the end of the case. So 1, to document how much blanching there is, and 2, with the goal of therapeutically rinsing the outflow system. And I document at the end of every surgery how much blanching there is. And one day I'll have a resident or fellow who can look at the results and try to determine if it truly is a prognostic factor or if we just think it is. So yes, I test blanching. I think it's useful. And although it's not evidence-based yet, my gut feeling and my instinct is that it is a useful process for prognosis and therapeutic purposes.
Thank you very much.
Thank you. I really wish I could be there. It's just, it's so painful to see you all having a wonderful evening in Panama, not being there. But thank you again to the Panamanian Society and to you, Lautaro, for organizing this evening. What a pleasure to talk to you all about such an exciting topic. Hopefully this can lead to curiosity and ultimately good outcomes for your glaucoma patients. So thanks again, and have a great rest of the evening. And hopefully we can connect soon. And if any of you see me at any meetings in the future, please tap my shoulder and say hello and say that we met in Panama at some point. So again, thank you very much to all of you.
Bye. Thanks a lot. See you soon. Bye-bye, Hady.
Bye, Lautaro. Thank you.